in November 5th in Boston. So this is a lecture that I try to fast forward. It's about 3 hours lecture. There's a lot of information about biobanking. You don't need that. But the focus of the interest for today's lecture is about the epigenetic regulation of hypoxia and heterogeneity in advanced cancer that we briefly talked about by prior presenter. You know, the protocol that I have developed is called multi-targeted epigenetic therapy, or MTET. So if you look at the handbooks and the schedule, it might be mentioned under different name, multi-targeted epigenetic therapy, or MTET. But the concept is the heterogeneity of the tumor and how the epigenetic regulation of these tumors, hypoxia, can change the biomarker signature of the tumor. So we're going to talk about that. And then I'm a clinician and I also am a scientist, so we're going to mix a little bit of preclinical information and the laboratory information with the actual clinical information. I also have some background in holistic medicine and naturopathic medicine, so I appreciate what Colleen initially presented. So we're going to talk about some natural products that we also use as part of our protocol in MTET. Okay, so the whole concept of epigenetics, how many people in the room are familiar with epigenetics? Okay, 2, 3, okay, good. So the whole concept of epigenetics, it's a philosophical term, first described by Postel. Epigene means that it's beyond genes, so it's not dictated by your genetic, let's say, Darwinian theory that you're destined to have cancer just because you have the bad genes. In other words, there are environmental exposures that change the genetic expression, so those genes that we call oncopromoters can or cannot be translated into the protein expression in cancer. So having a gene, a cancer gene, does not mean that you necessarily are going to get cancer. Why? Because this gene can be regulated by its expression through oncosuppressor genes, and these oncosuppressor genes, through process of epigenetics, can shut down the expressive genes. Usually when I give a lecture, I give my tie as an example. So you see this tie, and there are spots here, usually there are bands, but there are spots there. Imagine that these spots are bad genes. And there are some spots between those bad genes that are good genes. Those are oncosuppressor genes that suppress those oncopromoter genes. When the DNA looks like this, it's transcriptionally active. So it can express itself. Now we have CPG islands, cytosine guanidine island. I try to go very quickly in this. That promoter genes are located at. And these CPG islands can become methylated. That causes the DNA to become transcriptionally silent, what we call heterochromatin, like this. This heterochromatin is a DNA that cannot transcribe because these oncosuppressor genes are folded. It cannot function. When the DNA becomes unmethylated, or CPG islands become unmethylated or acetylated, it becomes transcriptionally active. This process of epigenetics is basically dynamic, so it can become folded and unfolded, and it's also a process that can be translated to the next generation. In other words, it's hereditary. So you see a lot of patients with lung cancer that these patients have never had smoked. When you ask them, you have an adenocarcinoma that only happens in the smokers, let's say it's KRAS positive, but these patients have never smoked. So when you ask them, they never touched cigarettes, but their parents have been smokers. So why this happened? Through the epigenetic process. You pay the price of what your parents did wrong. In other words, any sort of environmental exposure that we thought could cause cancer by causing deletions and genetic malformations in DNA, not only can cause that, but also in the next generation through the epigenetic process can cause the cancer. So that's called epigenetics. But the good information, good news about this is that it's reversible. So this DNA, as I said, it's a dynamic process. It can become silent and it can become active. This is a process that's dynamic. So the whole treatment of MTET, multi-targeted epigenetic, and all epigenetic therapies basically goes around reversibility of this process. So by methylating and demethylating different selective genes, you can actually reverse what your parents did wrong. So your father smoked, you got lung cancer, now you can treat your patient with lung cancer and you reverse the damage that the patient's father caused. Okay, now what hypoxia does in the whole epigenetic? One of the discussion that prior presenter had about biomarkers, it's very important because we have discovered that there are specific biomarkers, that these biomarkers correlate with the patient's survival. So as I said, heterogeneity of the tumor is one of them, and there are several other biomarkers. One is SUV activity of the tumor in the PET scan. So when you do a PET scan on the tumor, you look at maximal SUV activity of the lesions. Why do you do that? Because you want to see, besides the size of the tumor, what's the metabolic activity of the tumor. Why is it important that we look at the metabolic activity of the tumor? Because up until a few years ago, we thought that the size of a tumor determines the survival of a patient. So the response was defined, and it is even now, based on the RECIST criteria. So if the tumor shrinks, we say, hey, the tumor has responded and the patient is going to live longer. Well, that's absolutely wrong. The patient is not going to live longer just because the tumor has shrunk. The size of the tumor basically has nothing to do with the patient's survival, because it may change the patient's progression-free survival, but it has nothing to do with the patient's overall survival. That's one of the major problems that the FDA has, is that many of the drugs, especially anti-angiogenic drugs that have been approved, they have been approved based on the patient's improved progression-free survival, but not necessarily the patient's overall survival. However, the metabolic activity of the tumor, when you look at the PET scan, the metabolic activity of the tumor does correlate with the patient's overall survival. So that's why we never order CT scan. In my practice, every patient that comes gets a PET scan before we start the treatment and gets a PET scan after starting the treatment. When you go through the cases, you'll see these cases. Some of these cases have no changes in the patient's size of the tumor, but the activity of the tumor has dropped substantially. So that's one. The metabolic activity of the tumor is under the influence of hypoxia. So when the tumor is hypoxic, the metabolic activity of the tumor is higher. So that's why we're interested in hypoxia, because that determines one of the main elements of the patient's survival, which is metabolic activity in the PET scan. And hypoxia is under the influence of epigenetics. In other words, when you look at the renal cell carcinoma, you see that there's a gene, it's called VHL, and the VHL basically degrades HIF. How many of you have heard of HIF, or hypoxia-inducible factor 1? Okay, 2, 3, 4. So HIF is a key element in several pathways of the cancer daughter cell and the stem cell activity. One of them is epidermal mesenchymal transition. When a tumor tries to metastasize, when a tumor, again, all the subject of my talk is around overall survival. We want to know what changes patients' overall survival. And the patient's overall survival changes when you inhibit metastases, right? The original tumor does not kill the patient usually. What kills the patient is the metastasis of the tumor. What causes the metastasis of the tumor is epidermal mesenchymal transition. In other words, when you have a tumor, before this tumor is able to get to the blood, and before you identify any circulating tumor cell, these tumor cells have to go through a process of epidermal mesenchymal transition. Through this process, an epithelial cell becomes mesenchymal cell, it becomes rhomboid, and then it passes through the endothelial vasculature and it gets to the blood. Before this happens, the epithelial cell is not able to pass through the endothelial vasculature and go to the blood. So EMT, or epithelial mesenchymal transition, is necessary for metastases, right? What causes EMT through the pathway of Notch1, snail and slug, go down to Wnt, and going down to EMT is under the influence of hypoxia. So the tumor that is more hypoxic has a more tendency to metastasize. That's why we're interested in hypoxia as a marker as a biomarker actually, for patients' overall survival. Now you see here, we're describing This hypoxia-inducible factor 1 is degraded by VHL. So VHL is up, HIF is down. When the VHL is methylated, it cannot degrade the HIF. When the HIF is not degraded, the hypoxia is induced and the tumor can metastasize through the process of EMT. So that's epigenetic regulation of hypoxia. By demethylating the VHL, you can degrade the HIF. When you degrade the HIF, the EMT does not happen, cancer cannot metastasize. That's part of what our protocol MTET does. Now, epigenetic regulation of heterogeneity. Also, heterogeneity of the tumor is under the regulation of the epigenetics. And there are many, many biomarkers, including circuitry DNA, that prior presenter mentioned, that we measure. So when a patient comes to the clinic, this is what we do. We do a PET scan, we measure the CV activity of the lesion. Then we are going to check the secretory tumor cells, and we're going to check the secretory DNA. In the US, prostate, breast, and colon cancer are the only ones that secretory tumor cell has been approved for. But we use German labs that we look at every type of cancer secretory tumor cells. We measure not only the number of the secretory tumor cells, but we also measure the characteristics of the secretory tumor cells. So we look at the mRNA, and we find out what protein expressions of the secretory tumor cells are available. In fact, what you also can do is that you can culture the secretory tumor cells and see what protein expressions they have. We do all of that. Then this patient is going to be treated. After 2 weeks of treatment with MTET, we're going to repeat these tests. The scan does not change in 2 weeks. You have to wait for at least 4 to 6 weeks. But secretory tumor cells and secretory DNA are going to be measured again. Why do we check secretory DNA? Secretory DNA is a marker for heterogeneity of the tumor. There is a marker, it's called mutation allele fraction, or MAF. So when you do a secretory DNA through many laboratories in the US, Garden 360 is what we use, you look at these tumors biosignature of secretory DNA. For example, we find P53 mutation, PI3K mutation, you name it, and RAS mutation, and then after 2 weeks of treatment, then you repeat the secretory DNA. What you see is that if the tumor has responded, if the heterogeneity of the tumor has responded to your treatment, then you don't see the MAF decreases, so mutation allele fraction decreases. So instead of 45% secretory DNA with P53, now you see 15%. Does that make sense? Okay, so this is an example of the cases. So you see renal cell carcinoma. The first slide is before treatment, and this is the German lab that we use. It's called Biofocus. The dates on the first one is 5/13/2015, and the second one is 5/28/2015. You see, in a matter of about 2 weeks. That's exactly what I said. The telomerase was negative, negative, negative. C mice was positive, and so was G250. These two C mice, how many of you do know C mice or G250? So C mice has to do with, it's a mutation that happens in tumor that is very aggressive. There's no drug for it. It has to do with translation of mRNA. So tumors that have mutation C mice, they're very aggressive, there is no treatment for it, they have high expression of the protein in mRNA. And so is for G250. In fact, G250 is a marker for aggressiveness of the renal cell carcinoma. So NIH has done studies on vaccines against G250. There's nothing in the clinic yet, but G250 is a marker that is very important because yet there's no drug for it, and it explains why renal cell carcinoma is one of those tumors that is very hypoxic. In fact, as I said, VHL and the HIF was first described in a genetic aberration born people Lindo disease in renal cell carcinoma. And so G250 is a very important marker. And that's why renal cell carcinoma is almost always a death sentence. When you have renal cell carcinoma, it quickly metastasizes because it's hypoxic and usually recurs, although patient, remember what I told you, progression-free survival of a patient. I've wrote so many abstracts about this, that looking at progression-free survival is actually a fraud. Because when you look at the patient comes to you, you treat the patient, RECIST criteria is met, everybody's happy, the patient is congratulating the doctor for successful treatment and the tumor is shrunk or even disappeared. But guess what? You have caused, by this, you have caused a more aggressive tumor because you now, besides triggering the multi-drug resistance that your lecture was about, you have triggered the cancer stem cells. And either way, the patient's overall survival is not going to change. So why are we treating a patient that improves progression-free survival but causes a worse type of cancer? And I explained this so many times that the progression-free survival can, if it's improved, it can lower actually your overall survival. And in fact, when you treat patients, let's say with breast cancer nowadays, you use oncotype DX testing. You know that if a patient has early diagnosis or the oncotype DX score is low, using chemotherapy lowers the overall survival. In SO500 trial, what they did, they used the same circulatory tumor cells in breast cancer patients, stage 4. And these patients, the patients who had more than 5, as you know, the cutoff is 5 for cell search. Patients who have more than 5 circulatory tumor cells, they live less than 16 months with treatment and less than 4 months without treatment. So if you treat these patients based on circulatory tumor cells, let's say the first line of therapy, and you check the CTC again, you see that circulatory tumor cells are not responding to the therapy. We know that circulatory tumor cells do not respond to treatment because chemotherapy actually increases intratumoral hypoxia. Almost all chemotherapy agents, except 1 or 2 agents, they increase intratumoral hypoxia. They increase the tendency of the tumor to metastasize. That's why progression-free survival does not translate to better overall survival, because you increase the circulatory tumor cells. That's why SO500 trial failed, because after they switched the first line of chemotherapy to the second line of chemotherapy, they saw no improvement in the patient's overall survival and CTC. Multi-targeted epigenetic therapy, which is, if time permits, I will go over that in details, combines specific selective DNA and histone demethylators with histone deacetylase inhibitors, and this combination selectively unleashes these oncosuppressor genes in a wide variety of the solid tumors. You know, using the cytopine, for example, have been very well known for hematological cancer. They use it for myelodysplastic syndrome very widely. But in solid tumors, they fail. Why? Because the cytopine, despite its very potent activity on demethylation, it actually demethylates also the oncopromoter genes, which you don't want to demethylate. You have to use a selective demethylator that does not touch the oncopromoter genes. Because if you demethylate oncopromoter genes, they are going to express more. That's why, for example, you know, I've worked with, before this I actually gave a presentation, second international gastrointestinal cancer, and I presented a great data on gastric cancer. You know, on gastric cancer they have used the cytopine, and the cytopine basically caused worsening of the tumor because it also demethylates the line 1 gene and ABC2 gene. So this is briefly what it does. But this is, for example, in this case, you can see before treatment and after the treatment. After the treatment, C mice has disappeared. You see it's negative. I hope this. So here you see that C mice before treatment was positive, after treatment negative, G250 positive, after treatment negative. In a matter of 2 weeks, we were able to completely eradicate circulatory tumor cells. This is general rule. If a patient comes to see me, 100% of the time, I'm yet to see the first patient whose circulatory tumor cells have not completely eradicated after 2 weeks of treatment. This is second lung cancer, before, after. As you can see, before C-mice was positive, also was hisondiacetylase 1. Very good epigenetic marker, as you can see, was positive. So this tumor was absolutely epigenetically driven. After the treatment, you see that they were all negative. In other words, there is no indication for presence of secretory tumor cells after 2 weeks of treatment. This correlates with the patient's survival because you're checking the secretory tumor cells. The size of the tumor has nothing to do with patient survival. If you can destroy secretory tumor cells, then you can say that the patient is going to live longer. Okay. Questions? Yes.
Thank you. Thank you very much for a very nice presentation. Yes. Just I have one comment. You mentioned that all the chemotherapeutic drugs, including the hypoxia, will enhance the metastasis. But clinically, there are a list of drugs that are given only to reduce the metastasis. I am a pharmacologist, and there is a list of
Give me one example of a drug.
irinotecan,
Irinotecan, yes.
And the anti-vascular factors, a lot of drugs now.
Antigens. Let me educate you a little bit on this, because what you say is absolutely right as a clinician and absolutely wrong as a scientist. And let me tell you why. All anti-angiogenic drugs that block VEGF, they bind with VEGF or bind with VEGF receptor or both. So what they do is not that they reduce VEGF production. In fact, what they do is that they increase intratumoral hypoxia because there's a feedback loop between VEGF and HIF. So anytime that you reduce VEGF by blocking it, by binding to it, not the production, it's just like a river that is going and you put a dam on it. This side of the river, the dam, there is no water. So you think that the VEGF is gone. The other side, let me explain, the other side is building up. So these feedback loops have been recognized recently on the pathway of HIF and VEGF. So what happens is that, yes, they block the VEGF, the tumor vessels drop initially. That's why patient has a better progression-free survival. But generally speaking, and in fact, I was in 16 International Symposium of Anti-Angiogenic Therapy, and it was a disaster. You know what happened? Because I was very connected, and I am yet, fortunately or unfortunately, with the organizers of this. So they were talking behind the scenes, this should be the last anti-angiogenic seminar we can have. Because this is what the professor at the UCLA came by and said. He said, in all our trials that we have done, we treated more than 5,000 patients with Avastin. We could not see a single patient with any type of tumor that had any sort of response overall.
Even ovarian cancer?
Now, ovarian cancer is a little different. Especially ovarian cancer, you need to know that ovarian cancer, it needs to be combined with chemotherapy. So if you use it alone, it doesn't work. Even in ovarian cancer, and I have a lot of ovarian cancer patients who are on Avastin, if the problem is that if they have these sort of feedback loops, and it's sort of a luck, because if you never know if these feedback loops are going to be active and when, but it's going to happen. And that's why, yes, they show that there is minimum benefit. It's not a lot of benefit. There's minimum benefit in GYN malignancy. Recently in ASCO, where I was last year, they also talked about adding Avastin, for example, for endometrial cancer. But yes, think about it this way. Abbott, that they make the drug, they make $6 billion every year out of selling Avastin. And I can tell you that I have all these patients that come and they're on Avastin. And the first thing I do is that I stop it. Because these feedback loops, as soon as they get, and as I say, it's a matter of luck when it's going to happen. But as soon as it becomes active, the HIF pathway is going to break that down, and the river is going to flow very quickly. And that's besides all those notorious toxic side effects that I'm sure you've seen so many patients die of hemorrhagic. This is an unbelievable hypertension. Yes.